Hello and Assalamualaikum. Me and my friends will be present on the topic effects of drugs on oral mucosa. So, what is adverse drug reaction? An adverse drug reaction can be defined as an appreciably harmful or unpleasant reaction resulting from an interaction related to the use of a medicinal product. Adverse effects usually predict hazard from future administration, unwarranted prevention, or specific treatment, or alteration of the dosage regimen, or withdrawal of the product. Pathogenesis of drug reaction may be related to either immunologic or non-immunologic mechanism. Most adverse reactions to drugs are mediated by the immune system and are drug allergies. Three mechanisms have been proposed for drug allergies. Firstly, IgE-mediated reaction occur when the drug reacts with IgE antibodies bound to mast cell. Secondly, drug allergies can involve a cytotoxic reaction in which an antibody binds to a drug that is already attached to a cell surface. And the third one is mechanism in a drug allergy involves circulation of the antigen for an extended period, allowing sensitization of the patient immune system and production of a new antibody. For non-immunologic drug reaction, it's non-antibody dependent and may directly affect mast cells, causing the release of chemical mediators. Also, some non-immunologic drug-induced reaction result from a drug overdose or toxicity. The characteristics of the oral mucosa problems depends on type of drug, dose, and duration of treatment. For the diagnosis, we should take the patient history and recent use of the suspected drug. And for the management, withdrawal of the drug will improve the condition. So, we can divide the oral mucosa problem that caused by the drugs into common and less common. So firstly, we have oral ulceration, xerostomia, mucosal pigmentation, discoloration, and teeth alteration. And for the less common one, we have neoplasm, pemphigoid reaction, erythema multiforme, toxic epidermal necrolysis, lupus-like disorder, lichenoid eruptions, leukoplakia, and hairy leukoplakia. Firstly, we start with drug-induced oral ulceration. The definition of oral ulceration is a loss or erosion of the delicate lining tissue of the mouth. Typical oral ulcer due to drugs are clinically classified into two types. The first is widespread mucositis and ulceration, mainly caused by cytotoxic drugs used for anti-tumor chemotherapy. Widespread sloughing and ulceration arise within days of commencing therapy, with the associated pain often requiring opiate therapy and alteration or cessation of chemotherapy. The example of the drugs are methotrexate, 5-fluorouracil, desorubican, melphalan, and mercaptopurine. For the management, we can have the maintenance of oral hygiene, nutritional support, we can give systemic analgesics, and mucosal protective agent. The second type is fixed drug eruption, showing repeated development of treatment-resistant ulcer. We can see repeated ulceration at the same site and solitary or multiple large ulceration that are seen on every side of the oral mucosa. The common site is labial mucosa. For the drug involved, it is a wide range of drugs. For example, NSAIDs, beta blockers, barbiturate, sulfonamide, thiazide, and phenacetin. For the management, we can identify the causative agent and withdrawal of the cause and symptomatic treatment.
Next is drug-induced dry mouth. A wide range of medication have been found to be associated with xerostomia, which is the subjective symptom of dry mouth. Dry mouth can be defined as condition of not having enough saliva in order to keep the mouth wet. It is when the unstimulated saliva flow rate is below than 0.1 ml per minute and stimulated saliva flow rate at below than 0.5 ml per minute. Clinically, dry mouth can be detected by sticking the mouth mirror to the mucosa. So, if the patient have dry mouth, the mouth mirror will stick to the mucosa. Clinical features that patient with dry mouth may encounter are halitosis, thick and stringy saliva, dryness of the mouth, difficulty in chewing, speaking and swallowing, sore throat and hoarseness, rough tongue, changes in sense of the taste, and the last one is problem of wearing dentures. There are few management that we can do for patients with drug in the dry mouth. So the first one is by changing the medication that can cause dry mouth by letting the physician aware about the side effect of drug that they prescribe to the patient. Other than that, we can also prescribing medication that will help in stimulating saliva such as pilocarpine or zamivelin.
Next, I will be talking about the drug-induced mucosal pigmentation. It can be divided into two origins, which are exogenous and endogenous. For the clinical features of exogenous, it is located superficially, and the foreign bodies will direct implantation into the mucosa. For the endogenous, it is located deep in the mucosa, and there will be an accumulation of melanin. For the specific colors of both exogenous and endogenous, depends on the drugs involved. The pigmented lesions can be either brown, blue-gray, blue-black, and others. As for the left pitch, it is exogenous, which is due to heavy metals, and thus shows blue-black line along the gingival margin. And for the right pitch, it is endogenous, which shows hyperpigmentation of hard palate induced by chloroquine therapy, showing a blue-gray pigmented diffuse lesion with irregular borders. For exogenous, the drugs involved are such as chlorhexidine, iron salts, cocaine, minocycline, bismuth subsalicylate, and also lansoprazole. For the endogenous, the drugs involved are such as antimalarials, such as tetracycline, chloroquine, antifungal agents such as ketoconazole, antiretroviral agents such as SYAHMIRUL, and also oral contraceptive. For the management for both exogenous and endogenous, discontinue the medication or decrease the dosage. Next is drug-induced taste discoloration. It can be classified into two, which are extrinsic discoloration and intrinsic discoloration. For extrinsic, it can be either due to metallic or non-metallic, while for the intrinsic, it can be either pre-eruptive or post-eruptive. For extrinsic, the drugs involved are such as oral solutions or mouthwash and certain systemic drugs, while for the intrinsic, the drugs involved are such as tetracycline, fluoride supplements, and intracranial medicaments. The clinical features of extrinsic, if it is metallic stain, such as oral solutions or mouthwash containing metal salts, it can produce dark brown to black discoloration. As shown in the picture above, there's a dark brown extrinsic staining due to iron-containing medicament, while for the non-metallic stain, such as chlorhexidine, it can produce brownish discoloration. As shown in the picture below, there's a brownish discoloration seen at the cervical area of the lower incisors due to the extended use of chlorhexidine mouthwash. For the clinical features of intrinsic, for the pre-eruptive, such as chlorotetracycline, it can produce slate gray discoloration, whereas for the oxytetracycline, it can produce yellowish discoloration. As shown in the picture above, there's a grayish discoloration caused due to pre-eruptive administration of tetracycline. While for fluoride supplements, in the mildest form, it may appear as localized white flecks, and in the severe form, it may appear as diffuse opaque mottling with chalky white to dark brown color, and can even cause peeling of enamel, as shown in the picture above on the right side. There's a white opaque fleck seen in an individual from a non-endemic area that could be attributed to excessive fluoride from an artificial source. While for the post-eruptive, such as minocycline and intracanal medicaments, it can cause greenish blue discoloration of teeth, as shown in the picture on the right side. There's a greenish discoloration of maxillary central incisors as a result of the placement of intracanal medicament containing minocycline. For the management of drug-induced teeth discoloration, control the dosage of the drugs and reduce its period of exposure.
Next, I'll be explaining about the drug-induced teeth disorder. From the definition, it can be categorized into 3 different types, which is hypogeusia, ageusia, and dysgeusia. Hypogeusia is a blunting or decreased sensitivity in taste perception. Ageusia is a total loss of the ability to taste, and dysgeusia is a distortion in perception of the correct taste of a substance. For example, sour for sweets. The clinical features for this taste disorder is not just loss of taste, but it can also be as an abnormal taste in the mouth. It can be an unpleasant taste or an electrical sensation. This taste disorder can be detected clinically by doing special tests. These tests will be done by using 4 standardized sizes of filter paper that will soak with a strong concentration of 4 basic tastes and placed randomly on the 4 quadrants of the tongue and both sides of the soft palates. The patient then will identify the quality of the taste and rate the intensity with a number from 1 to 10, with 10 being the strongest. But bear in mind that this clinical test only for detecting and measuring the degree of the sensory loss, but it is unable to determine the cause and give neither prognostic information nor therapeutic guidance. Therefore, it is important to really understand the etiology for this taste disorder from the clinical history assessment. Next, this is an example of drug that can induce taste disorders. The first is antithyroid, which is to treat hyperthyroidism. Aurothiomelate, that also known as cold sore, that used to treat rheumatoid and psoriatic arthritis. Next is aztreonam, which is an antibiotic used to treat infection caused by gram-negative bacteria such as Pseudomonas aeruginosa. Diclofenac is a muscle relaxer and recognized as antidiabetic. Calcitonin to treat osteoporosis. Next is captopril and cilazapril as antihypertensive. Metronidazole as antibiotic. Penicillamine that used to treat Wilson disease and cystinuria. Last but not least is protease inhibitors that act as antiretroviral. The management for this drug-induced taste disorder is we will consider to eliminate any suspected drugs that can cause taste disorder, and will treat any dry mouth or mucosa disorder or hematinic deficiency. And it is advisable for the patient to chew food well to increase the release of tastings and saliva production, and always remind the patient to drink well.
This is a case study of a 70-year-old Caucasian woman that was referred by her dentist to an outpatient clinic with a 4-week history of an oral ulceration. She had a history of Bessel cellular carcinoma in her face and stomach. From extraoral examination, the patient showed facial symmetry, but palpable, mobile, smooth, and asymptomatic submandibular lymph nodes. Intraoral examination found that the patient has a shallow ulcer with erythematous border with 1.5 cm max diameter. The ulcer was located in the mucosa of the lingual region of her left lower premolars, and she also reported painful symptoms. As for the medical history, the patient reported that she had cellular carcinoma. So what is cellular carcinoma? It is a type of skin cancer that begins in the Bessel cells. Most Bessel cell carcinomas are caused by long-term exposure to ultraviolet radiation from sunlight. It usually develops on sun-exposed parts of the body, especially face, ears, and neck. So as the patient has a history of skin cancer, she was worried about the possibility of the ulcers being an oral cancellations. From the clinical examination, as I mentioned before, the patient's face was symmetrical and her lymph nodes were palpable and asymptomatic. As the picture shown here, upon the intraoral examination, the patient has a shallow ulcer with diameter of 1.5 cm at the lingual region. Upon further examination, the patient reported the use of Sertraline Hydrochloride for the treatment of depression at an initial dose of 50 mg. It was subsequently increased to 100 mg when the occurrence of the lesion was first noted. Sertraline hydrochloride belongs to the group of drugs called selective serotonin reuptake inhibitor. It works by inhibiting the uptake of the serotonin by platelets, which will increase the serotonin level in the brain. It is used to treat depression, panic attacks, obsessive-compulsive disorders, post-traumatic stress disorders, and social anxiety disorder. Here is a picture of the usual brand that sells sertraline hydrochloride, which is the Zoloft, where one tablet is equal to 50 mg. After evaluation of the medication by the physician responsible, the sertraline was replaced by 75 mg of venlafaxine, and exfoliative cytology of the ulcer was performed. Exfoliative cytology is a way of an early detection of oral cancer. It is a microscopic examination using Papa Nicolau stain of shed cells or harvested cells from body surfaces by rubbing or brushing the lesion surfaces. From the observation of the lesion, it showed that there is superficial and intermediate pavement epithelial cells presenting diverse inflammatory and degenerative alterations such as vacuolizations and a perinuclear halo. It has enlarged nucleus, binucleation and lysis, with numerous leukocytes, thick and filamentous mucous and cell remnants, in addition to a mixed flora consisting of bacteria and candida hyphae.
The management for this patient is mouth rinsing with betamethasone elixir 3 times per day for 3 minutes. It was initially prescribed for 5 days, and upon her return, the patient presented with improvement on the clinical symptoms and was instructed to continue mouth rinsing for additional 7 days. Betamethasone oral solution is a corticosteroid. It helps to reduce swelling, redness, and irritation in the mouth. It can be used for the treatment of mouth conditions that cause soreness, such as mouth ulcer and oral lichen planus. Other than that, a replacement of 100 mg sertraline hydrochloride with 75 mg of venlafaxine. Oral ulcers can be manifested from systemic diseases of immunogenic origin such as Behçet disease. Diseases such as pemphigus and pemphigoid may also impair differential diagnosis with non-specific secondary ulcer. In such cases, a biopsy combined with immunofluorescence is a fundamental tool for a definitive diagnosis. Ulcers can be caused by deficiencies in iron, folic acid, B12 complex, B6 vitamins, and zinc. Several studies also evaluated the use of drugs may induce the formation of ulcers. including medications such as nifulmic acid, captopril, pirozivcam, and phenobarbital. Cytotoxic agents used in cancer therapies affect dividing cells that can also induce ulcers in some patients. Exfoliative cytology should be the complementary examination of choice in cases of oral ulcers with a suspicion of drug interaction. Though this is a rare event in dental practice, dentists should be aware of the diagnostic possibility of drug-induced ulcers and should cooperate with the clinician to adjust the prescribed medication for resolution. Here are our references. Thank you.